Okay, we'll get started. So I'm Katie Warren. I'm the neurologist at Meadville Medical Center. I know lots of you, but I don't recognize everybody. So thank you so much for coming. Again, sorry for the delay. So does everyone here have headaches or just here for out of interest or a little bit of both maybe? Yeah, headaches. Okay. Well, we'll see if we can shed some light on that and hopefully give you some ideas about where to go from where you're at right now. So just a little background on me, which I'd like to kind of start with when I'm meeting a new group. I'm from Fredonia, New York. My small hometown hospital is Brooks Memorial Hospital, which is in Dunkirk, New York. And I grew up there my whole life, and then I went to Allegheny College here in Meadville. Went to LECOM in Erie for med school, Albany Med for residency, Buffalo for fellowship, and I came back. So I'm kind of near from the area, and I've lived here on multiple different phases of my life, so I'm happy to be back. So the first thing we're going to talk about with headaches is we'll go through the objectives and then kind of get started on the meat of the talk. So the first thing is when someone has a headache, I think a lot of people, especially when it's a new headache, a lot of people are concerned that it means something very bad. There are things that are dangerous and things that we need to watch for, so we'll list what those are. The next thing is figuring out what kind of headache is it, and we'll go through the different types of, the most common types of headaches, and what kind of features we see that help us narrow that down. Then what is the cause of those headaches once you figure out what the diagnosis is, how do we treat it, and what should you expect in the long run? So the first thing are the danger signs, and in medical school we learned that there's an acronym called SNOOP, so hence Snoop Dogg in the bottom right. So if it helps to remember these are things that you should be watching out for or have friends or family watching out for if they were to have a new headache. So if you have other symptoms in your body with a headache, such as a fever, that might be a concern for something like meningitis. So that's, that's dangerous and needs to be treated urgently. Other neurologic symptoms, so N for neurologic symptoms, and that would include anything where typically one side of your body is affected. So if you have a problem somewhere in the left side of your brain, it's going to affect the right side of your body, and a patient might report that they feel numb on one side or weak on one side with their headache. And that, again, if it's affecting one side of the body, most people know that is mostly concerning for a stroke. Strokes themselves don't typically cause headaches, but bleeding in the brain does, and they can look a lot alike in a patient. So it's always important to get that checked out urgently. If you are not a headache kind of person and all of a sudden you get one, which I assume probably doesn't apply to this group, but again, friends, family, if it's not something you've experienced before, if it's a change in the type of headache you've experienced before, if something is different about it, sudden onset, so not something that kind of built up over weeks to months, but something where you woke up suddenly and had it, or out of the blue at work, all of a sudden have a very severe headache, that's dangerous. Other features, if someone has hit their head and has a headache, most of the time that will probably just be bumps and bruises and maybe a concussion, but sometimes a pretty good knock on the head could cause bleeding in the brain, so that's important to check out. If the pain wakes someone up from sleep, that's concerning. And if the headache comes on with exertion, so meaning exercise, even just something like maybe walking or climbing stairs, if that always seems to trigger a headache, that's something else we need to watch out for. And then I kind of mentioned previous history with a change. So if you tend to always have headaches in the front and all of a sudden now you have a headache in the back, it might not mean anything, but it is a change, and that's something we should evaluate more closely. So this is a list of a lot of the types of headaches. I'm sure it's not a totally complete list, but I kind of tried to include the most common things we see. And we're going to focus on the top part because they do include 90% of the headaches that we see. Migraine by far is the most common, at least that I see in neurology. Tension headaches are very common, cluster headaches, and medication overuse or rebound headaches are surprisingly common. And that's one that I think education is really important to avoid. There are several other types that I listed below, but when we've ruled out some of the more common causes of headaches, sometimes we're looking for those other less common causes of headaches. And they can affect different age ranges and things, so they're not as common, but something else that we see as well. So which is it? how do we figure this out? So there's a list of questions, and I think if some of you grabbed some of the paperwork that we brought, there's a list of questions that we ask our patients to figure out what kind of headache it is. So the first is onset. When in your life did the headache start? So for some people, they started having them as a teenager. And especially for women, and we have all women in the audience today, except for Dwayne, that puberty is actually a very common cause of migraines, especially in a female with family history of migraines. It's very common. And then it can happen, again, in women especially, it can happen whenever there's a hormonal change. So that could be every menstrual cycle thereafter, that could be pregnancy, delivery, and even menopause. And unfortunately, most women think that after menopause they're kind of in the clear, but in fact some people actually start getting their headaches after menopause because of the hormonal fluctuations. Sometimes actually treating with hormones can improve headaches, and in some cases can make them worse. So finding out exactly when they started is an important step to the diagnostic process. And then next is, did they start suddenly or gradually? So again, did you wake up with this one day and it's been there ever since? Or is this something you noticed, well, I used to have them once or twice a week, now it's every day, and it's kind of been gradually getting worse? What happened when you started getting the headaches? So this can be tricky to figure out. I mean, somebody clearly had a car accident and hit their head on the windshield, that's pretty clear, we can figure out what they came from. But was it, in an adolescent again, was it around the time that someone maybe started their period? Or did they change medications? That's a big one. If someone started a new medicine, say a week or a month before they started getting headaches, they might not think of that as being a cause of their headaches, but maybe it was. And again, this birth control comes to mind because that's actually a common trigger for headaches, either starting birth control or stopping birth control, changing the type, things like that. And there's a lot of other medications that headache is a side effect of the medicine. And so if you had someone prescribe you a medication and you think it might be causing problems, you can ask the doctor that prescribed it and say, hey, is that one of the common side effects that we should watch out for? So that can help us figure out, again, what the cause is and the type of headache. Next, the time of day. So this is really important, actually. Finding out, do they tend to happen when you wake up first thing in the morning? Is it when you are laying flat before you actually get out of bed? Is that when the worst of the headache is? Is it worse halfway through your workday and your workday's been very stressful and maybe that's bringing on the headaches? Or a lot of times in adolescence, again, it can be dependent on like what time of the week it is. Is it the weekend? Is it the weekdays? Is it stress from school, stress from work for older individuals? So time of day can be really helpful. Frequency. In the migraine world and the headache world, the way we treat patients that have frequent headaches is by counting the number of headache days per month. So a lot of people will describe typically per week, which we can figure out the math pretty easily on that. But that's kind of how we calculate our treatment plan, if it's working or not, is by how many headache days someone has a month. And many people, there's a certain type of headache that we'll talk about a bit later, that actually the headaches happen multiple times in one day. So then kind of keeping track of those numbers and keeping a log and a diary can help us narrow that down as well. And then the duration of the headaches. Is this seconds to minutes, minutes to hours, hours to days, days to weeks? Is it constant, chronic, all the time? Does it fluctuate throughout the day in severity? Is it the morning you still have a headache, but it's not as bad in the morning and then it gets worse later in the day, or vice versa? So those are the really important things to kind of keep track of when you have headaches, and discussing those details with your doctor can really help us narrow that down. So next, just to break it down a little bit with a picture, is how can we figure out where the headaches are coming from. Sinus headaches tend to be, of course, where the sinuses are. So sinuses are in the forehead, in the temples, and they can extend even back to the jaw area. So if people have pain or pressure in that area, that can lead us toward that direction. Cluster headaches are not that common. A lot of people, I think, maybe get misdiagnosed with cluster headaches. We'll talk more about those in detail, but again, those are typically happening just behind one eye. Now, migraines can happen the same way, so there's other features that we're looking for, but they definitely have to be on one side. And again, I'll describe those a bit more later, so we'll understand those. Tension headaches tend to be on both sides of the head. So a lot of people describe them like a band or a vice around the whole head. They can be right across the forehead and not typically lower in the face like a sinus headache would be. And then classically, migraines are on one side of the head, But I would say, that's kind of the what's taught, but I don't think that that's necessarily what we see in the office. So there's a lot of other features that go along with these that help us narrow it down. So how do we figure out with testing what might be going on? So the first thing is typically you want to get some kind of picture of the head, whether it's an MRI or a CAT scan. Whenever I'm ordering these kind of tests, I describe to my patients that a CAT scan is like an old digital camera, or an old Polaroid camera, and an MRI is like a fancy digital camera. So they both take us the picture of the same thing, but the CAT scan is going to give you kind of a grainy, fuzzy picture. It doesn't give you a ton of detail. An MRI is much more detailed. The resolution is so much better. We can see tiny pieces of anatomy very well. And in fact, now at Vernon, we have a very strong MRI machine, and the detail is really quite amazing. So the picture I included here is actually of an MRI, and that's a slice through the brain right down the middle this way. So you're looking kind of at the side of the brain from the outside in. And I think a really important point to point out at this with this slide is that most headaches don't cause a change in the brain that we can take a picture of. So pain does not cause anything you can see with an MRI. I think that most people would assume, and understandably, that if we get an MRI and you have migraines, we're going to see something. In fact, if we see something, that's probably not a good thing, because what we don't want to see is a tumor, a stroke, a bleed, multiple sclerosis, things like that. Most headache syndromes have nothing to do with a structural problem with the brain. It's kind of more of a functional change in the brain, and it's at the microscopic level, and we can't see that. So I hope and I expect that 99% of the MRIs we order for patients with headaches are going to be normal. If they're not normal, then you've got more concerns actually. So I think that's a common misconception that's helpful to understand. Can't take a picture of pain. It doesn't mean you don't have it, it just means we can't take a picture of it. In rare cases, we do a lumbar puncture or a spinal tap. That is not that commonly done. There's certain types of headaches we need to do those for, but most of the time that's not necessary. A sleep study or polysomnography is a sleep study that is done for another type of headache that sometimes we need to rule that out. And then there's some labs that we can do for headaches, but there's not a whole lot of labs that can help us narrow this one down. So that's not as necessary. So first, we'll talk about the tension headaches. So the way that someone describes tension headaches is more of a dull discomfort in a band-like distribution around their whole head. They'll describe they feel like there's a headband actually, like sitting on the head or like a hat, and the hat's too tight. The cause of tension headaches is that the muscles on the scalp that are kind of attached to the outside of the head are too tight. And they're over-contracted. So imagine like a muscle spasm in your leg, you get like a Charlie horse, that kind of thing. It's literally the same thing. These muscles though are very thin and wide, and so they don't cause a ball, they actually just kind of affect the whole muscle and make it tight. And because the direction of where those muscles are attached, that can cause pain in those distributions. So if you have, you can see on the picture, the fan-like muscle on the side of the head, if that is the tight muscle, then that's primarily where the pain is going to be, but that wraps around to the other side too, so then you'll feel it on both sides. Some triggers of tension headaches can be pretty common with a lot of the other types of headaches as well. Stress, mood changes, head injury, alcohol or hangovers can cause a tension headache. Caffeine, either caffeine use or caffeine withdrawal. That also can trigger other types of headaches too. Dental pain, so TMJ or temporomandibular joint dysfunction, if you feel cracking in the jaw pain, that can be a trigger for tension headaches because the muscles are directly attached to that joint, and so that can trigger those muscles to become irritated. Vision strain, so if someone hasn't had their eyes checked in a while and headaches have been kind of coming on gradually over time, especially let's say at school or when at work using a computer screen a lot and they're having to strain to see what they're looking at, that can trigger a tension headache. And fatigue. The treatment for these are pretty conservative. The massage therapy directly to the muscles that are affected can be helpful. Over-the-counter pain medicine, so that's things like Tylenol, and ibuprofen, Motrin, naproxen, things like that. Opiate medications, so narcotics, can be used for headaches. We try not to use them very much, but sometimes they can be helpful. more so for tension headaches than for other kinds of headaches. And then muscle relaxers are not used for a whole lot of types of headaches, but tension headaches, it makes sense because we are trying to relax that muscle. And there's a lot of overlap between these headache types, so sometimes it's not that straightforward. Then sinus headaches are another fairly common type of headache, and again, like I said before, the sinuses are right across the forehead, down the nose, and into the cheeks, and back to the temporal area, and that's where people will feel pain, but it's more of a pressure than it is of a dull discomfort. The cause of it is actually inflammation inside those cavities of the face. When there's inflammation from whether it's allergies or an illness of some sort, the drainage of mucus doesn't happen as easily, and then when that builds up, that causes increased pressure inside the sinuses. But again, that really should only be right in the front. There shouldn't be any spread to the back of the head. These can increase when you bend over or strain. So if you have, again, a lot of mucus built up or congestion built up in the sinuses and you bend over, you can imagine that more of that might build up, and that can cause some increased pain. Symptoms would be other symptoms of, kind of being sick or having allergies. So congestion, runny nose, cough, swelling of the eyelids or the lymph nodes, fever, and sore throat. But sometimes you don't really have any of those other symptoms, and it's just really more sinus pressure. And then the treatment is really focusing on sinus treatment rather than headache treatment. And so you want to use a humidifier, drink lots of fluids, use warm compresses to the face, and some over-the-counter medications can be helpful, especially decongestants. So cluster headaches, these actually come from a structure inside the brain called the hypothalamus. The hypothalamus is our body clock. It helps to set your circadian rhythm, so when you're awake and when you're asleep and how much sleep you need. And what happens with these types of headaches is there is a severe, excruciating, debilitating pain that focuses right around one eye. And like I said before, migraines can feel a lot and look a lot like that. However, with cluster headaches, patients get a runny nose on the same side as the headache. They get tearing in the eye on the same side of the headache. They can have flushing, so their face looks red on that side of the headache, where the headache is. They can have changes in sweating, so they can actually sweat too much or sweat too little from that side of the face. So they have to have those other features. They can't just have the pain, whereas again, migraine would have the pain but not those other features. They also have a very different cycle of the duration and the frequency of the headache. So they start suddenly, they stop suddenly, they happen multiple times a day, and they're fairly brief compared to some other headache types. So they only last about 15 to 120 minutes. They happen about the same time each day, typically at night. So this will wake someone up from sleep, and they'll have these horrific attacks over and over and over again for maybe, say, a few hours each night, and then it'll go away. And it won't happen again until the next night, and that it's very predictable, and in fact, would prevent people from sleeping if that's their cycle, which can be very debilitating as well. And then the cluster of the cluster headaches lasts weeks to months, but then they might go years and never have another one for quite some time. And the treatment is actually interesting. Treatment's oxygen, so people use high flow oxygen when they're in their cluster headaches. And so that's very different than a lot of the other types of treatments. And triggers are alcohol and tobacco, and then risk factors. It tends to happen in men, and it also tends to be genetic, so it can run in families. So again, this is a pretty rare type and can be confused with migraines, but it's important to keep in mind those other symptoms that have to happen with it. Well, that didn't come out quite right. So medication overuse or rebound headaches. This type of headache is usually daily, every day, usually around the whole head. And it happens when someone takes a medicine to stop their headache more than 2 or 3 times a week. So this tends to be, you have a headache, you take your Tylenol, and first thing in the morning, and then by noon, the headache starts creeping back again, you take another Tylenol. And then you get home and you're making dinner, and then your headache comes back and you take another Tylenol. And you end up getting in this vicious cycle where it's better for a little while, you treat it, it's better for a little while, you treat it, and then unfortunately, once your body kind of gets used to that cycle, it ends up, it's very difficult to get out of, and you'll end up taking it day after day after day, and ultimately, for months on end even, and it can be really dangerous, not just for the headaches, but also because most of those over-the-counter medications either get processed by the liver or the kidneys, and it can be very dangerous for the organs, and there's blood work we can do to check on that, but from a headache treatment standpoint, the easiest way to avoid this type of headache is not to take so much of that medication. But what do you do when you have a headache every day and you need to reach for something that's going to make you, get through those next few hours? So we can talk about how we do that later. But I certainly understand how people end up getting into this kind of cycle. Other symptoms that can happen with the rebound headaches are nausea, mood change, restlessness, difficulty concentrating, and memory loss. Under my font there, you can see the treatment is you have to just stop the medication. It does get worse before it gets better, but I promise it'll get better. It can take several weeks. It's like you're literally withdrawing from a medication and your body has to kind of wash it all out and you have to start fresh. And it definitely will, when you're going through the withdrawal, you'll definitely notice a worsening of the headaches. But you have to kind of try to push through that and not reach for that medicine because it's only going to continue that cycle. And usually after a few weeks, once that's completely gone, we either find that someone actually has no headaches, or they might still have headaches, but certainly not the same frequency, maybe once a week or something like that. So that's the best way to get rid of that one, is just stop it altogether. And then once you've stopped it, you get a good idea of what is your called baseline headache frequency. So how many headaches do you really get when you're not taking those medicines all the time? And that will help us figure out what the actual diagnosis is that's causing the headaches, and then what the right treatment is. So migraines, so that's kind of where I focus most of my treatment for patients. This is an abnormality of the nerve that provides sensation to the head and the face. It's called the trigeminal nerve. And there's also some suggestion that the chemical serotonin in the brain can be altered in patients with migraines. They tend to start in adolescence, but can happen anytime. And other types of headaches can trigger migraines. So you might have a sinus infection with sinus pressure, but then maybe that builds up and then can trigger a migraine. So they don't necessarily have to happen independently from each other. Before a migraine, some people will describe what we call a prodrome. They can either have constipation, neck stiffness, or interestingly, yawning can be a prodrome for a migraine. And aura, though, is something I think more people are familiar with. This is what happens within minutes to an hour or so right before a migraine. It's not actually all that common for people to get an aura. Most people don't have an aura, but for those that do, it's very predictable and can allow them to treat it early before it turns into the bad migraine. The most common example is people see some sort of vision change. So they either see squiggling lines in their vision, they'll describe like a firework pattern or sparkling lights or shapes, or just black spots in their vision. And again, then within 30 minutes or so, they will get the headache part of it. People can also get tingling, oftentimes in the face, and sometimes there can be some changes in mood prior to that as well. Then when the migraine starts, it's again classically unilateral on one side of the head, but it does not have to be. The description that people describe with migraines is that it's either throbbing or pulsating, and the reason for that is the blood vessels that are in the scalp is where the migraine is kind of coming from. And so as those blood vessels are pumping the blood through, you literally feel the pulse, and that's why it feels like a throbbing or pulsating. And then the typical symptoms that happen with migraine is nausea, vomiting, light sensitivity, sound sensitivity, smell sensitivity, blurry vision, dizziness, and others. And then these can last for hours to days, as opposed to the cluster headaches that are more 15 minutes to a couple of hours. And then the frequency is variable. So some people, again, are once a month, some people are daily. So that can help us figure out what the right treatment is. So what are the triggers for migraines? And again, a lot of these triggers are similar for the other types of headaches. And I did include this in some of the handouts, so you can take that with you. And everyone has different triggers, but sometimes looking at this and doing kind of a diary and narrowing it down, what are your triggers, that can help if you can avoid those, which sometimes they're not avoidable, but if you can, sometimes that can help decrease the frequency of headaches. Some of the common ones, especially dietary-wise, are chocolate, cheeses that are aged cheeses, especially those with, it's a chemical called tyramine in them. Monosodium glutamate is MSG. MSG is a preservative in a lot of foods, and it is classically found in Chinese food, but also in Doritos, apparently. So, and I'm sure there's lots of other things that have that in it. So MSG is a fairly common trigger, so that's something to watch out for reading food labels. Aspartame or other artificial sweeteners are pretty common, so avoiding things like diet drinks. So diets, whether it's diet soda, diet juice, diet iced tea, things like that, that are going to have an artificial sweetener in them. Caffeine again can go either way. Some people swear by it. They say it helps their headaches, and for some people it triggers their headaches. And then there's some people that stop drinking caffeine and it's a withdrawal headache that has nothing to do with migraine. So caffeine can kind of cloudy the picture a little bit. What else? Talked about kind of the hormonal triggers we already talked about. Lights and odors can be triggers, stressors, and then weather changes are a big one. When there's barometric pressure changes, those can trigger headaches. Typically, I see that more with sinus-related headaches, but they can certainly trigger migraines as well. Skipping meals, not eating regularly, not exercising, things like that can be triggers for certain people. So most people, I think, have episodic migraines, meaning that they happen less than 15 days a month. However, many people, and probably most of the people by the time they get to me in neurology, they are more than 15 days a month. So anywhere between 15 and even 30 days a month. And it doesn't necessarily mean that every day is a migraine, but every day is a headache. And many of those days are migraine. And you can tell the difference. If you're a headache kind of person, you can tell the difference. What's your headache and what's your migraine? And how many days of the month are they headaches and how many days of the month are they migraines? If you have 8 days a month with migraine features, so that's the nausea, light sensitivity, things like that, and the auras, 8 days a month with that, and the other 22 days a month or so are headaches, that's called chronic migraine. So that's when something has transferred from an episodic to a chronic state. That means that pretty much every day there's some form of a headache. Again, they don't all have to be migraines though. When someone has a migraine though, a true migraine with those associated symptoms for more than 72 hours, that's called status migrainosus. And sometimes it can be treated at home. We have some ways we can try to help do that on the outpatient side. We have medication in the office that we can give someone in an injection form to try to stop status migrainosus. But oftentimes, unfortunately, it requires IV medicine. And so that can either be given in the emergency department, or in some cases, even people get admitted for 5 to 7 days on IV medicine just to stop their headaches. So those are pretty rare, fortunately, but that's the way we treat those. In terms of risk factors, what can make your headaches go from episodic, meaning hopefully not that often, to very often? Things that are those risk factors would be being female, having a family history of migraines, having a history of some sort of head or neck injury, having a stressful life event that then can trigger those episodic migraines to turn chronic. Younger patients tend to be more predisposed to getting more chronic headaches. Underlying psychiatric disorder, and this could just be depression or anxiety. It doesn't have to be a major psychiatric disorder, but those can certainly play a role. And then other chronic pain. So if you have other neck pain, back pain, joint pain, things like that, they tend to kind of come together, and those patients can be a little bit more difficult to treat. What can you do that's modifiable risk factors? So if you are taking the rescue medicines too much, that's back to the medication overuse or rebound headaches. If you're taking those medicines too often, that can certainly switch you from episodic to chronic, but that's an easy fix. You just stop the medicine. If you snore, or if you're very tired during the day, that would suggest that you might have sleep apnea. And using a CPAP has a lot of benefits, not just related to headaches. It actually can protect the heart and kidneys in the long run. But from a headache standpoint, if patients with untreated sleep apnea have headaches, often in the morning, wearing a CPAP at night, which allows them to get the right amount of oxygen when they're sleeping, can decrease headaches. Again, typically the ones that happen in the morning. If they're later in the day, that might not have an effect. But again, if somebody tells me all my headaches are right when I get up, that is something we definitely have to check for. So that's with the sleep study. Caffeine, again, that can trigger a lot of headaches that can be avoided. And obesity is something that hopefully could be improved upon, but can be a modifiable risk factor for headaches. Chronic migraines. Again, we talked about a lot of different types of headaches, and a lot of them are treated the same. There's some variation that I talked about before, but ultimately a lot of them have a lot of overlap, and so we use a lot of the same treatments. So on the outpatient side, what can you do at home? The NSAIDs, or anti-inflammatory medications, are pretty commonly used. Of course, that's ibuprofen, naproxen, Aleve, Motrin, all those kind of things. Tylenol is a non-NSAID, but that's obviously available over the counter. Triptan. So the class of triptan medications are things that a lot of people have heard about, like Imitrex. So sumatriptan is the generic for Imitrex. There are several other triptans though, so rizatriptan, elatriptan, zomatriptan, and they all have other long names that are brand names, and they're available in pills and injections and nasal sprays. So those all can be used at home when someone feels that onset of a migraine coming on. And then there's a lot of other treatments that people know by other names. So the first one there I have listed, acetaminophen, aspirin, caffeine, is Excedrin. So that's obviously available over the counter. And then the other ones are prescription. So the next one is Furacet, the next one's Furanol, and then Tramadol. And all those medicines, again, can be prescribed by your doctor for when you have a headache. This is what you take. This is not, these are all medicines that should not be taken too frequently because, again, that's going to cause the rebound headaches. My kind of rule of thumb is no more than 10 days a month. If someone needs the medicine more than 10 days a month, then those types of medicines are not the answer. There's a whole other list of medicines we'll talk about. But if it's once a week or so, those can certainly be used safely. Then on the inpatient side, when someone has that status migrainosus or needs IV medicine for a headache, there's the classic cocktail a lot of people maybe have gotten in the ER that is Toradol, Reglan, and Benadryl that can only be given in the ER or in a hospital setting. In the office, we have Toradol, but only in an intramuscular injection, not an IV injection. So it's not maybe as effective, but could be much more easily given without having to go to the ER. So, and then Reglan and Benadryl, obviously, we can give those as prescriptions or Benadryl over the counter, and you can have that at home as well. And then there are other IV medicines, Depacon, DHE, and Solumedrol, and some others that we use. Actually, magnesium is becoming more and more popular, a high-dose IV magnesium to treat, again, these are headaches that you're in the hospital for. This isn't something we do at home. So then what do we do for the long-term treatment? There's a lot of different options there. So the top there I listed what we call non-invasive treatments. So those are things that are not going to be injections and things like that. So limit those abortive medications. Again, those are the rebound, the meds that you take too often, they'll cause rebound headaches. Tylenol, ibuprofen, things like that. Changing the lifestyle based on your triggers. So if your trigger is chocolate, don't eat chocolate, and then you've modified that, and then you wouldn't get as many headaches. There's a lot of supplements that can be used, and I have a list of those I'll go over with you. And you could take those on as a prevention medicine to decrease the number of headaches you're getting each month. If the headaches are more of a tension type headache or are being triggered by neck pain, physical therapy and massage therapy for the neck can be helpful. There's behavioral therapy, chiropractic manipulation. And recently I had a patient get this device called a T-band. I had never heard of it. I Googled it. I don't know much about it. There's no research about it, but it kind of looks like a Fitbit. And when he took it off, there was actually these little metal balls on the underside of it that were making contact with his skin. And he said he wasn't really sure what they were either, but maybe copper and various other metals, I don't know exactly. But he swears by it now and hasn't had a headache ever since he started wearing it. Whether it's placebo or not, I have no idea. But something else to try out there. Then the next step would be medication, and I'm going to get into those at the next slide. But then the last category is more invasive treatment. So these are things that would be injections. So some people get acupuncture. A lot of people ask me about the daith piercing. So that's the piercing I have the picture of there that goes into the cartilage deep inside the ear. It has to be done in exactly the right location for it to work. And so I always tell people if you're going to pursue that, make sure you find a person piercer who is familiar, educated, with this procedure. Where does it go? What is the purpose of it? I usually say maybe call up a couple places and say, hey, can you do the daith piercing? And if they say, I can pierce anything you want, probably don't go there. Maybe find another place that has, oh yeah, we were trained in that. I know that there's a few places nearby that sent their staff actually to Pittsburgh for a training program on how to do this properly, and even will follow up with the patient within 1 or 2 weeks and see did it help their headaches, and make sure it doesn't get infected and things like that. And then they can actually do the other side. Sometimes they usually just do one at a time because when it's healing and you're sleeping, you don't want to have it on both sides because then where do you sleep? If you're a side sleeper, I guess. And then some people tell me that once it's in, it might even work right away, or maybe it worked, but then it stopped working if they wiggle it. I guess that's supposed to trigger something. It's supposed to be like an acupuncture point, and that's how it can relieve the headache. So similar to acupuncture in that area. But again, it's not something that's been studied. There's no evidence to support it. But I'd say about 50% of the patients actually do pretty well with it. So it might be worth a try. I certainly not opposed to it. I recommend it for those that are interested in pursuing it. The worst that's going to happen is it gets infected like any other piercing. You take it out. Usually it's not too big of a deal. There's a few other injection type treatments. Occipital nerve blocks are an injection that's done by pain management, and they are put in right at the base of the skull where one of the nerves comes out in the back. So if the headaches are primarily in the back, not the neck, but the back of the scalp, the base of the skull, there's a nerve there called the occipital nerve, and you can get an injection right there, and that can help those types of headaches. Next is a trigger point injection. So these are more for the type of headaches that have a muscle tension associated with them. So if it's shoulder muscle tightness, neck tightness, tightness of the muscles of the scalp, they can put a medication right into that muscle and calm that muscle down if it's triggering those headaches. And then Botox injections, and that's kind of one of my primary treatments. We're going to get into more detail with that. That is a treatment that people get on a regular basis to prevent their headaches, similar to the other types of treatments. But that's one of the more aggressive ways to go, and kind of takes quite a bit of commitment on the part of the patient as well, because there's frequent visits and things. But we do that quite a bit in our office, and we have a lot more information to share with you about that. So when I'm evaluating a patient, I think I see them on the tables. Most of you have that. It's the one that has the Botox icon on the top right and the Meadville Medical Center icon on the top left. There's a two-sided document. So on the front side, there's a whole bunch of questions, and they kind of go over a lot of the things I already described. So when did they start? Where are they? How often do you get them? What kind of triggers do you have? And I use that with patients that I see in my office. And then on the back side, it has a list of all the medicines that we can use. And the top part of the chart are all the medicines we use for prevention. And I'll talk a little bit about what that means. And then the bottom part are what we call the rescue medications or abortive medications. That's what you take when you get a headache. And again, the bottom part is only 10 times a month or less. Obviously, this is very small. I don't mean for you to read all the words, but just to point out that there's a lot of options and a lot of different categories that we use. So the first column you'll see if you have the paper in front of you are the supplements. Riboflavin or vitamin B2, feverfew, magnesium, and butterbur are very natural ways to prevent headaches. And these are things you take every day so that you get less headaches. So in a 30-day period, again, the goal would be to get, let's say you have 30 days a month, the goal by taking these medications is to bring that down by at least 50%. My goal is, everyone's goal is 0, but if we can get it down to 15 headache days a month or 5 headache days a month, then we're heading in the right direction. So those supplements are easy to get. The B2 and the magnesium are at any store, CVS, Walmart. The feverfew and butterbur are a little bit more difficult to find. They're more commonly at a place like GNC or a specialty store. Don't need a prescription for any of those though. If you're looking for dosing recommendations though, I do have that information as well for those medicines. The next category, the antidepressants. I don't use them for depression per se in patients with migraines, although if someone does have both depression or anxiety and migraines, then this is a good category to choose. There's a lot of different medications here that we can try. I'd say the most common and most effective ones I use would be the amitriptyline or Elavil, the very top one, and then probably Cymbalta or duloxetine closer to the bottom there. Those are more effective. The next category are the anti-epileptic or seizure medications. Again, I'm not prescribing these for seizures, but we know that the way that they work for seizures is they're decreasing the brain's kind of excitability, the electrical over-signaling going on. And so that can decrease headaches too if you find the right medicine. And Topamax, the third one down there, is hands down probably the most commonly prescribed headache prevention medicine. So you take that every day and it should bring down the number of headache days that you're having. And then gabapentin is pretty common as well. Used for a lot of other reasons, but for headaches can be used as well, especially when they're coming from the neck. And then Depakote, the top one, is a very effective medication, not used as much anymore because of some of the side effects it has, and can't really be used in women of childbearing age because it can affect fetal growth if a woman becomes pregnant. So I don't use a whole lot of that. There's some other nasty side effects with Depakote, like weight gain, acne, and hair growth where you don't want it. So most people don't really want to take that. Then the next three categories are all different blood pressure medicines. Beta blockers, the first column, are the most commonly prescribed for headache prevention. And all of those, again, I'm not prescribing them for blood pressure, but if someone also has high blood pressure, then it might be helpful. Now, if someone has low blood pressure, I clearly can't use those medicines. So that's how we kind of can narrow down what would be the best bet for someone. So once we've kind of established what are all the medicines that someone's tried, and we kind of like literally take this piece of paper and I circle all the medicines that someone's tried, and maybe they haven't tried very many and we have a lot of options, or maybe they've tried a lot of these and we don't have a lot of options, and it kind of helps me narrow down what direction to go next. Then on the bottom, again, we kind of talked about a lot of these already, but the abortive medications or rescue medicines, these are taken 10 days a month or less. I'll point out if there's anything else that stands out. The nausea medicines, actually, I didn't talk about a lot. Yeah, that's the third column there. Nausea medicines actually they're taken for two reasons. One is because a lot of patients with migraines, of course, get nauseous, and that's helpful for that symptom. However, the nausea medicines actually can also treat the migraine itself. They don't just treat the nausea. And Phenergan is kind of the classic one known for that, on the bottom there. Reglan is actually pretty commonly used too, especially in the IV form in the ER. I think that people don't tolerate Reglan quite as well, so I don't use a lot of it. I think Phenergan works pretty well. Zofran is a very good nausea medicine, but not necessarily for the migraine type nausea. Did I say that backwards? Zofran's a good nausea medicine, not necessarily for migraines though. And then the last category, we did touch base on a lot of those already, Excedrin being one of the most common people use over the counter. So as I said before, when we're trying to figure out which way to go with the medications, we take into consideration what other medical conditions does someone have. Do they have depression, other pain, neck problems, how do they sleep? There's medicines that are going to make you drowsy, and there's medicines that aren't going to make you drowsy. Can we make you sleep better by using a medicine that does make you drowsy? And again, blood pressure, does someone have high blood pressure, low blood pressure? Are those medicines safe to use? Then talking about side effects. So of course, every medicine has pros and cons. And so whenever we're going through the list of options, we have to keep in mind what side effects seem manageable, reasonable. And my rule of thumb is that if I give anybody anything that does not agree with them, I don't want you to sit home and suffer with that for 2 months until your next visit. Call your doctor, call me, and we would change it. I certainly don't want you to suffer with side effects. If they are manageable, let's say you have a little bit of drowsiness or a little bit of tingling in the fingertips from some of the medications, maybe that's manageable, and then you can stay on it if it's making a difference for the headaches. Rule of thumb too, always start low, go slow. So we always start very low doses because of the side effects. We don't want to ramp you up on a medicine to the highest dose right away. We take our time because you want to be on it for any condition, the lowest effective dose without side effects. You don't need to take the highest dose if it's not necessary. So we start low, go slow. And then the other thing is you want to make sure you try any of these medicines for a long enough amount of time to know if it's going to make a difference. A lot of the medicines we use in neurology, they can take 3-4 weeks to have an effect. And so it's to try it for a couple days and say, my headaches didn't get any better. That doesn't kind of fly with me because it's not long enough. So what we have to do is give the first 3 to 4 weeks enough time for that medicine to kind of kick in, and then you start counting for 30 days. How many headaches do you have in 30 days? If it's less than it was before you started the medicine, then I would say it's helping. It's not, these medicines, when we're choosing the prevention medicines, they're not intended to stop a current headache. You don't take Topamax, for example, for a headache and stop a headache today. It is a long-term prevention medicine. So if you take it every day, then next month, hopefully you have 15 days a month instead of 30 days a month. But it's a hard thing to wrap your mind around because you want to feel better right away, of course, and you don't want to take something that you're not noticing benefit from. So a lot of people end up stopping them, and if we don't give it, and from an insurance standpoint, which shouldn't be the focus, but tends to be sometimes, if we don't try it for 8 weeks is the minimum for insurance, it limits other medicines that we can use down the road. So I always request 8 weeks per medication if it's tolerated. Again, if someone has side effects, it's off the table, but if it's tolerated, we got to give it 8 weeks and then monitor the headache frequency again, counting by days of the month. So when someone has tried a whole bunch of those medications that we went over and they still have too many headaches a month, so meaning 15 days a month or more, and 8 or more of those days of the month are migraine, then the diagnosis is chronic migraine. And if we run out of pill options, or if we've tried like certain types, then the next step is Botox. And that's what I've kind of been focusing a lot of my practice on here in Meadville. So there was a study done in between 2006 and 2008 called the Preempt trial, and they studied about 1,400 patients with chronic migraine, and they used these, Botox. Most people think of Botox as being for wrinkles and things, but it has a lot of other medical uses actually, and chronic migraine being one of them. So they would do these injections, and I'll show you about where the injections go. They do the injections every 12 weeks or every 3 months, and it's 31 injections in the head. And I do them all in about 2 minutes, so it's very fast, but there are many injections, and you get that treatment every 3 months, and that is instead of taking a pill every day. So if you've tried your Topamax and your amitriptyline and your propranolol, and the headache frequency is still more than 15 days a month, then this is in place of that. So you don't take pills and this. Now, if Botox works well and your headache frequency gets down from, let's say 15 days a month to 5 days a month, you can still take the rescue medicine for those 5 days a month. So that's where your ibuprofen, Excedrin, Tramadol, Furoset, those things come in. But hopefully if it's working, you're taking it a lot less often. So that's safer for you in the long run. You won't get the rebound headaches from it. And you won't have the same side effects from taking them so often. They also, let's see, I was gonna add one other piece there. Forgot where I was going with that. I'll try to remember what that was. So the studies did show that there was a significant decrease in the number of headache days per month. This is class 1A evidence, which is the highest level in kind of the medicine world. And so it was approved by the FDA for the use for the treatment of chronic migraine in 2010. And it's done in a very certain pattern, a certain way. So it does need to be done by someone who's familiar with it. And it is an expensive treatment. However, it is covered by insurance. And we know with as much as we're doing it now in Meadville, we have over 200 or so patients now and I can't actually take the credit for this. Kathy Yeager takes credit for this. She is my Botox coordinator extraordinaire. And honestly, she knows the insurances through and through and is able to get this covered. When I know that we've gone through the right steps and someone's eligible for it, it gets approved. We know that. So it is expensive, but usually when covered by insurance, it is definitely affordable. And it's important to keep in mind that when that's the treatment, you're eliminating a lot of other treatments that would have cost money anyway. So we'll go through that a little bit more. So how does Botox work? Botox is a toxin, technically, where it was kind of found in the environment, but it's been made synthetically to kind of reproduce that. And what it does is it prevents the secretion of chemicals between a nerve and another nerve. So the little yellow balls is basically where one nerve is kind of attaching to the other nerve, and they secrete chemicals that kind of swim across the way there, and they tell the other nerve to signal pain. So what Botox does is it prevents those chemicals from being secreted at all. So it literally stops the signal of pain before it even starts. Unfortunately, it's not infallible. There's certain nerves that still will signal that pain, but again, for the most part, it'll decrease the headache frequency quite a bit. So where do the injections go? The white dots on this model here show you where the injections are. So there's 7 in the forehead, 4 over each ear, 5 in the back of the head, between like the middle of the back of the head and the top of the neck, and then 3 on each shoulder. And again, those are done fairly quickly with a very, very small needle, very small amounts of medication, and I do them within about 2 or 3 minutes or so. It's very well tolerated. I think that people tend to have the most difficulty with the first one only because they're nervous, understandably, about getting the injections. They don't know what to expect. But I always joke with my Botox patients that on Botox day, they keep coming back despite having 31 injections because it really does work that well. It can honestly be very life-changing for people. So I wasn't sure if this was going to work. Nope, it didn't. Well, maybe I'll demonstrate this later. That last slide was a video that I uploaded to show you how the injections are done. but it doesn't appear to be working. So I'll show on that later. That's okay. I'll finish this up and then I can show on the model. So another common question people ask, of course, is what are the side effects of Botox? So one of my pet peeves with the package insert, the information that comes with Botox, or if you Google it, is that they kind of lump the side effects of Botox into a list that does not separate them by where the injections go. So for example, if someone has a stroke and they have a very tight muscle, their arm gets contracted up like this and they can't open their arm, and if I inject the bicep muscle, it makes that muscle weak, and it allows it to open up. It decreases how tightly it's contracted, and it allows them to open their arm up, which can help them with cleaning, dressing, and comfort. If I inject, maybe a patient has cerebral palsy, for example, and their muscles of their legs are very tight and their feet are kind of cramped up, you can inject those muscles and loosen those muscles up so they can move more normally, and maybe it's easier for them to walk, or it's easier for them to get in and out of a car, things like that. Now, Botox injections for migraines are given in the forehead again, in the side of the head, the back of the head, and the shoulders. So those muscles in the forehead, if they become weak, what you may notice is decreased wrinkles. So most people aren't too concerned about that, but one of the injections is right here in the middle, and I have had a handful of patients tell me that they can't make this face. Most people, again, don't really care about that, but I 1 out of 200, again, this is pretty rare, but because of the weakness of this muscle, it made this muscle kind of pull up a little bit, and it can make the eyebrows kind of tilted, and so she told me that her husband thought she was mad at him or something like that. But all these women still come back. I mean, it doesn't prevent them from getting it, and any side effect like that wears off within 3 months because the medicine only lasts for 3 months. So that's really just the facial ones. That's the only place where I've really seen side effects. Now, when I inject the muscles over the ears, that muscle, if it were to become weak, isn't going to cause you anything noticeable, right? So your ear's not going to fall off, So that's not usually an issue. People don't notice any changes there. Same with the back of the head. The muscles that are in the back of the scalp itself, you're not going to notice if those muscles are weak. And of course, if there's hair covering it up, you don't even notice where the injections went at all. I have a lot of male patients too, some with less hair, and maybe you notice that a little bit, but for most of the patients, it's all covered up anyway. And then there's a few injections on the shoulders and the trapezius muscle. The trapezius muscle is a huge muscle that goes across your whole back. So if I put 3 tiny injections into the trapezius muscle, they're not enough to make that muscle weak. When they say that muscles can become weak all over the body and you can have double vision and you can have trouble swallowing and trouble breathing, what I don't think that they really specify is where did those injections go, And so I wish they could kind of separate that out for what the indication was for in the first place, but they don't. So again, the worst that I've seen is not being able to wrinkle their forehead, and they all still come back anyway. So I think something that's really meaningful with Botox injections, because we like I said, it's an expensive treatment, but again, covered by insurance, is to think about what is the cost without Botox for a given patient. And most of these patients are on a daily prevention medicine, whether it's Topamax, propranolol, amitriptyline, Cymbalta, all of that list of medicines I gave you. Many patients are on more than one of those, even up to say 4 or 5 medicines they take every day. So if you go to your pharmacy and you fill that prescription every month, and it's whatever, $20, and you multiply that by 5, there's $100 right there for 1 month. That's just your prevention medication. Then you've got your abortive medication, so maybe you take Imitrex, maybe you buy Excedrin over the counter, maybe you have Tramadol, maybe you have a nausea medicine. So how much do those cost every month if you're having 10 or more headache days per month and you're taking those regularly? A lot of patients end up going to the ER to get IV medication. Sometimes monthly, they go to the ER for IV medication. Not many times patients get even admitted to the hospital and they're on IV medicine for days on end. And, especially with like deductibles and things in the beginning of the year, that could be thousands of dollars. So those prices can really add up. And then not to mention, people miss work for migraines, they miss school for migraines, they miss functions with their family and friends. And so that may not take a toll as much financially, although with work it may if you have certain restrictions with work, but certainly can take a toll on the cost of quality of life. So that's something to keep in mind. With Botox, honestly, my experience is, bless you, that it is so effective that we are able to usually stop all the prevention medications completely. The rescue medications are used so much less often that the prescription lasts for months and months. Patients literally stop going to the ER or being admitted. And they're not missing work and school and events. And I wish I could say it's 100% of the time. I'd say honestly it's close to 90%, and I'm not even exaggerating. It's really, really great. From an insurance standpoint, every, of course, plan is different, but we have found with our practice that around $200 to $250 for, again, a 3-month treatment. So this is every 3 months. So this isn't a 1 month, copay. This is for 3 months. Is around $200 to $250, and some insurances it's $0, for that copay. Now, if you have a deductible, of course, in the beginning of the year there can be a heavier load up front, which can be difficult to afford. And so then we have patient payment programs. We have the hospital has a patient assistance program, and the company that makes Botox also can help us with the cost of that too. So there's definitely ways to get around it. And it's been very rare. In fact, I think only 1 patient so far, 2, that have not gotten it because of insurance restrictions with cost. Not that it wasn't covered, that they didn't support the use of it, they just couldn't pay their portion of it. So, but again, if you divide whatever that responsibility is by 3 per month, is that less than the combination of everything else that you're doing? And so that's kind of what we try to present to patients and see if it's worth it. And we have a lot of information about that we can discuss more afterward if you have any questions specific to you. So kind of the summary and pearls of wisdom to take away. Watch out for those red flags that we talked about in the beginning. It's important to figure out the type of headache, and the way we do that is to understand all of those questions we talked about. When does your headache start? How often does it happen? How long does it last? Keeping a diary for a month or 2 is really helpful to identify triggers, especially. If it's every time you eat chocolate, if it's every time you have red wine, if it's every time you don't eat something, you're hungry or you're tired, are these things that you can avoid if possible? When you take a medication for it, does it help you? So unfortunately I have some patients come in, they say, I've taken ibuprofen. Well, does it help? I don't know. So if you can jot down, before I took the ibuprofen, it was an 8 out of 10 in intensity, and then I took the ibuprofen and it's a 4 out of 10, then you can say, okay, yeah, it helped, it didn't take it away, but it decreased the severity of it. And that's important information, because maybe ibuprofen isn't the right answer, but maybe a stronger anti-inflammatory is the answer, and so that can help me narrow that down as well. Also, pictures don't equal pain, so most of the time, again, you're not going to see any abnormality on the MRI, the CAT scan. The only reason we do that is to make sure we're not missing something else like a tumor. Of course, unfortunately, everyone thinks that that's what it is right off the bat. It's usually not. We want to see a normal picture. That's what we expect. And then speaking about treatments, again, there's a lot of conservative treatments to try. There's a lot of prevention medications that can be tried, and a lot of rescue medications as long as they are used sparingly. And then you want to treat the headache as soon as it starts, because that can prevent it from progressing into a much more severe headache later on. So that's my family. Does anybody have any questions? Oh yeah, big trigger, definitely. I have actually one woman who's a teacher locally, and I wrote a letter for her to give to her boss to allow her to use soft light lamps with the lights. I don't know if they were like the halogen type where it was like pointing toward the ceiling, or if she had them covered, they were pointing down, but not, like she didn't have any of the fluorescent lights anymore. That's a big trigger, definitely. And there can be modifications if it's something within like a workplace or something that can be done. And again, to not have to use those. So. Thanks. They're older. That's an old picture. They're 3 and 6 now. They're like 3 and 1 there. So if you don't have any more questions specifically for me up here, then we have a lot of information about some of the treatments we have in the office. And I also brought Camille, which is a head that we use to demonstrate where the Botox injections go. It's not it's not too gruesome. It was lent to us by the company that makes Botox. So if that is all, then feel free to come on back, answer any more questions. And if anybody wants to see me in the office, I have business cards back there as well, and we can talk more about it. All right. Thank you for having me. And sorry again for being late. Sure.
I get these where I move my eyes.
It's still on the desktop. Yeah.
I get dizzy and I get the real sharp pain top of my head.
So when it's eye movement, that can be a sign of pressure behind the, like pressure inside the ventricles of the brain. Well, it could be sinuses. So I guess I think of sinuses as non-neurologic because it's not the brain per se, but kind of outside. So definitely could be sinuses or pressure inside the brain itself. So the spaces in the brain where there's fluid, you can actually develop too much fluid, and that puts pressure behind the eye. And an eye doctor can diagnose that there's a couple different tests. An eye doctor can see the swelling behind the eye if they do a dilated eye exam, and then that's the one where sometimes a spinal tap is helpful to diagnose it. The treatment is very different than it is for migraines because you actually have to get the fluid out. It's not just treating a pain. It's like literally draining out the fluid. So.
Well, I've had migraines since I was like 5, but my migraines quit. Now I got this every 2 months I get this pressure. I move my eyes. The only way it goes away if I lay down.
So if you lay down, it gets better. So that actually would suggest it's not pressure behind the eye or sinus issues. It can be that migraines can change over the course of your lifetime. Especially when you're 5. Every time you have like a hormonal change, the characteristics of the frequency of the change as you get older. So it could just be